Much for doing this, sir.
Yeah. My pleasure, Akshay, and thank you for the nice words. So, shall we start?
Yes, sir.
So the topic is evident, as Akshay has already briefed about it. So what is the objective for today's presentation? We'll see what is liver steatosis, what does the fat do to liver, where does it lead to, just what is our role. So first of all, there is a change in terminology. So earlier we used to call it as non-alcoholic fatty liver disease, but now it's changed to steatotic liver disease. Steatohepatitis is now called as metabolic dysfunction associated steatohepatitis, because they wanted to remove this alcohol thing from the title. And non-alcoholic fatty liver disease is now called as metabolic dysfunction associated steatotic liver disease. So MASLD and MA-MASH. There is one combo entity with rise in alcoholism. There are a lot of patients who already are at risk of fatty liver, and alcohol is an add-on toxin. So that is called as MET-ALD. ALD is for alcoholic liver disease. So as we see that obesity is rising, let me start with a case study. So here on the CT scout, you can see obese woman, and she came to CT scan for a very non-specific complaints. Because she was obese, the gastroenterologist thought, let's do a CT scan. So this is the first time scanning of the patient. Patient did not have ultrasound because of her body habitus. What we see here is that there is a renal stone. The liver is fatty, and you can evidently see the nodular margins in the liver. And there was a focal hypervascular lesion here in segment 6 of the liver. And you can see there is hysterectomy. So the patient has a history of endometrial CA. So this is nothing but an epitome of metabolic syndrome. She's a classic case of obesity, hypertension, diabetes, endometrial cancer. As you know, obesity is a risk factor for endometrial cancer. And this is our first presentation with a HCC and cirrhosis. So before this point, the patient didn't know that she had this problem. So it was a very silent disease. And what we today see is almost an epidemic. So metabolic syndrome encompasses obesity, high blood pressure, dyslipidemia, mainly high triglycerides, low HDL cholesterol, and the most important thing is insulin resistance. So now there is epidemiological full reversal. Viral hepatitis is now the third leading cause, while fatty liver disease is the most common cause for liver disease. And the main pathophysiology revolves around insulin resistance. Insulin resistance is nothing but the reduced ability of the cells to absorb and use the blood sugar for energy. So it is initially it is in a pre-diabetes stage. By HbA1c, anything below 6.2 and above 5.7 comes in pre-diabetes, and gradually this patient progress to type 2 diabetes if appropriate intervention is not started. So then it is not the fatty liver is the only problem. So you have obesity, insulin resistance, diabetes, which leads to fatty liver, cirrhosis, and diabetes itself leads to cardiovascular disease, and then cancer. So what is interesting is the in fatty liver patients, the most common cause of death is not cirrhosis or HCC, but it is a cardiovascular disease. So when you see a fatty liver and you intervene, you are preventing deaths from cardiovascular cause as well. So the spectrum of fatty liver is like when the fat starts depositing within the hepatocytes, means it deposits in the cells. It starts triggering change in the liver physiology and some morphological changes happen. The normal liver can progress to simple steatosis or simple fatty liver, which can then progress to steatohepatitis. Or sometimes the patient can directly present as steatohepatitis, and eventually that leads to cirrhosis. Now, around 20% of liver disease can progress to steatohepatitis, and around 0 to 4% progress to cirrhosis, and it takes around 10 to 20 years. Typically, a steatotic liver disease may have mild raised transaminase levels, but it is not uncommon to have normal LFTs. So normal LFT can, you may think everything is normal, but it may not be. So let me show you this example. Here, this is a lean person, lean guy who has fatty liver. The liver is not nodular, but you can see that liver has some changed in shape, and there is diffuse fatty liver. But if you see, all the lab tests are in the normal range. Worrisome part is developing HCC, that is liver cancer, in cirrhotic patients. But the more alarming thing is you can have HCC without developing cirrhosis. So anyhow, above 70, the incidence of HCC rises in non-cirrhotic patients, but those with fatty liver are also at higher risk of developing a HCC. So some people even say that fat is carcinogenic. And once steatohepatitis develops, this risk of HCC goes by 10-folds. Idea of the prevalence of steatotic liver disease. This is a general population, and this is the obese patients. And you see the majority of obese patients are either having simple fatty liver or they have steatohepatitis. When I say steatohepatitis, I mean inflammation in the liver. Once you develop steatohepatitis, the risk of cirrhosis is much higher. And the risk factors, when you see a fatty liver, look for these findings, whether the patient is diabetic. You can check a BMI by taking weight and other parameters in your ultrasound clinic or a CT. Patient's age of more than 50 years, and if there is raised aminotransferase enzymes by 2 times. Now, this is a Indian story which is quite remarkable. India has around 60 million type 2 diabetic. This is based on the documentation. Undocumented number is much higher. Around 70%, that is 44 million people of this diabetic, 70% diabetics have fatty liver disease. Initially, which is a benign thing. And 80% have steatohepatitis, where the liver has inflammation. And 5% of steatohepatitis will eventually develop liver cancers. So out of those 60 million, 65,000 liver cancers we are looking at. Now let's dig into the pathology, what actually is liver steatosis. So if you see, this is a hepatocyte, while this one looks different. It's looking different because there's this fat globule which is sitting inside the hepatocyte. The fat deposition within the hepatocytes is in 2 stages. At initial stage, the fat globule is small, which is not pressing on the nucleoli, and that is called as the microvesicular fat. And the same fat globule, when increases in size, it starts displacing the nucleoli, and that is called as a macrovascular fat. Now, this is not a simple thing because cell in the human body is a functional unit. So they have multiple organelles. They have a cytoskeletal structure. Like each hepatocyte will have its like Golgi bodies, mitochondria, and other structures. Now, what happens? This fat cell has now sitting inside the hepatocyte. It is increasing in size. It is displacing the nucleoli. So it kind of affects the skeletal structure of the cell. So then the inflammation starts. So like here, this is just fat, but here you can see neutrophils have come up in the image. So the inflammation has started. So when you have fat in the, as it's steatosis, and then you have neutrophils, meaning the inflammation has started, then this all leads to a stage called as ballooning. Now I'll give you a good example of ballooning. Tent, which has bamboos which hold the tent. But suppose if one of the bamboo on the sides break, the air kind of balloons your tent. So same thing happens in a hepatocyte. The cytoskeletal structure is, I won't say destroyed, but it is distorted, and the cell becomes sick and it dilates. So when you reach to this stage of steatosis, inflammation, and ballooning all together, it is called as steatohepatitis. And this is the stage where you have to be like active intervention is required. So this is a hepatic lobule which is hexagonal in shape. That is the central vein, and in this hepatocytes there are multiple hepatocytes in a linear line, and these are the portal triads. So this is how the hepatocytes look. They are like a linear lines coming from the central vein and going outwards. Inflammation starts, and you know, anywhere in the body if there is inflammation, the healing is by fibrosis. So the fibrosis staging on pathology is done by something called as Metavir grading system. F0 is no fibrosis. F1 is minimal fibrosis. F2 is a stage where the fibrosis is going from one hepatic lobule to other hepatic lobule. Then comes the stage 3 where they are interconnecting to each other and they start involving the portal triads. So again, this is again an alarming stage where intervention is required. There's the start of advanced fibrosis, because if it is not controlled at this stage, it will progress to a stage like this, where there is a lot of established fibrosis in the liver. The hepatocyte anatomy is distorted, and whatever is left between those fibrotic areas are called as the regenerating nodules. And then there is conversion to HCC. You can see in a hepatocytes, the NC ratio is much higher, so many nucleoli you can see. As radiologists, we are the gatekeepers. We have to take a very responsible part here. And that is what I was telling Akshay, that IRA has started preventive imaging mission, where we are going to pick up multiple things like osteoporosis, fatty liver, and other things. But right now the focus is on fatty liver, and we do on elastography and other talks and held workshops all over India. So we have almost done 15 workshops in last 2-3 years. So as a radiologist, our first job is to identify fat, and we try to quantify it. So let's see. So you always look at the liver in relation to the kidney, and you assess the echogenicity of the liver. If the liver echogenicity is more, then you call it a fatty liver. There is a problem. These patients are obese and quite severe fatty liver. The posterior visibility is too limited. So in such cases, you have to order a cross-sectional imaging for better assessment. Now, quantification of fat can be qualitative just by looking at the echogenicity and the portioning of the posterior liver because of the attenuation. But then now there are multiple options available where you can even quantify fat on ultrasound. This is out of my purview as I don't do ultrasounds, but something like PDFF, which is used in MR, there is ultrasound derived fat fraction. Then there's a hepatorenal index where you measure the values by a ROI on the liver as well as on the kidney, and then you create a ratio. And scan is also bit of ultrasound based, which gastroenterologists use, and they give a CAP score, which also tells you about the fatty liver. The disadvantage with fibroscan is you don't have the pathology as you see on ultrasound. So a lot of work is going on this to quantify fat on ultrasound. Easy and relatively accurate way is to do a limited plane CT scan through the upper abdomen over the entire liver and spleen. And there are different ways to quantify fat on CT. One of the simple ways, you just measure the HU value on the liver. Make sure you don't put and a normal liver with pathological absence of fat at 120 kV, the HU value is around 64. If you are below, then that is significant fat. The other way, which is very popular with the liver transplant team, it is called as a liver attenuation index, where you take a mean HU value of the liver, mean HU value of the spleen, and then liver minus spleen. So if the liver has HU value, mean HU of 60, spleen has 50, then liver attenuation index is plus 10. So like such a patient is suitable for as a liver donor. Then some people also use the liver splenic attenuation ratio, but the two popular ones are HU of the liver alone or looking at the liver attenuation index. The MRI, let's understand what is in and out phase imaging, which is the base sequence. So it's also called as chemical shift imaging. When you do a in and out phase T1 rated image, it gives you two sets of image. The first set is called as the in phase image, and the second set is called as the out phase image. So what happens in an in phase image, the fat as well as the water signal add to each other. So when there is fat, the liver actually appears little brighter. Whereas in out phase, the water and the fat proton processing in opposite directions. So they actually cancel each other's signal, and what you see is a signal drop in the liver. So that tells you that there is fat in the liver. So this is a quantitative way where you say, okay, the liver is slightly bright on in phase and there is drop on the out phase. So this is fatty liver, but more important is to give a quantification. So there is one step ahead of the this chemical shift imaging is Dixon sequence, which gives you a set of 4 images: the in phase, out phase, the fat image, and the water image. So you can actually draw ROI and you get the fat percentage, but that is little cumbersome. You have to do it at multiple places. But there is another problem. A standard Dixon sequence, if the fat quantification has some issues, it is not very accurate. There are certain confounding factors, like there may not be a true separation of the fat and the mobile protons. There is a T1 bias. Then there is noise and early decay of signal. Plus the fat itself is complex. This is a MR spectroscopy of vegetable oil. This image is from AJR, no, it's from other journal. You can see the fat has multiple peaks. One of the peak is a major peak. So you should be able to identify and take in consideration other peaks also. So because of these disadvantages, the same Dixon sequence goes into one step further. This is now called as a proton density fat fraction image. The accurate separation of the water and the fat protons, and this gives a ratio, and you get a percentage. Now this is considered very accurate. It has been validated on multiple studies. It is reproducible on a different vendor machine also, and it is a biomarker of hepatic steatosis. So it is even superior to liver biopsy. We'll talk about it a little later on that. So in a normal Dixon sequence, there is one in phase and one out phase at two different echo times. But in a proton density fat fraction, 6 echoes are used, and you get this color map, which is very easy to make out. It can give you fat quantification on the ROI based also, and there is also automated the computer software gives you the fatty load of the entire liver, which comes as segmentation volume, and it tells you about the iron content also. So if you have a patient who has iron overload, sequence can give you accurate fat estimation. Now PDFF is nothing but more on the same principles as MR spectroscopy, and MR spectroscopy is a reference standard for PDFF. It is much more accurate than that, but you have to place multiple boxes and it is cumbersome. So for practical purpose, PDFF, that Dixon based sequence is good. So now that we have identified fat, we have done quantification based on the imaging we are using. Now there is a big window before cirrhosis is diagnosed. That is almost 10 to 20 years. So in the initial stages, it will not have the classical features. So we have to detect the early signs of chronic liver disease, and we should also detect cirrhosis. Gold standard is liver biopsy, but there are disadvantages of liver biopsy. Number one, it is invasive. You can't apply it to a large population, and the sampling error. So you are just sampling 1 in 50,000 of the liver volume. And I would like to tell you that the liver is not always homogeneous, same everywhere in the liver. It can be heterogeneous. One. Number two, fibrosis in the liver never starts at the same time everywhere. So there may be area of liver which may have grade 1 fibrosis, some area may have grade 3 fibrosis. So liver biopsy is not, as of now, not PDFF MR available. It's not recommended anymore. except in select situation. Other thing is when pathologists give their fat percentage, they only look at the macroscopic macrovesicular fat. Those fat globules which are large enough to displace the nucleoli. So they only take those that fat into consideration. So they miss on the microvesicular fat. So the PDFF MRI takes account of both microvesicular and the macrovesicular fat. So it is more accurate. How do we grade fibrosis on imaging? So for that, there is shear wave elastography. Now, before coming to elastography, let me tell you the different stages as liver cirrhosis is formed. So how MASH cirrhosis is different? It is a very slow process. There is mild fat deposition, then goes to moderate, then goes to severe. The fibrosis is also gradual and happens over a long period. Initially, there is hypertrophy in the liver. There are areas of the liver which starts getting hypertrophy. While in the advanced stages, the liver actually loses fat. The LFTs start becoming normal as cirrhosis develops. And at a later stage, a classic appearance comes and then the LFTs get dearranged. So if you see this axial image of these two patients, you can see that the liver surface is smooth. But then you can make out that abnormality is there. And when I do 3D, I can easily say that this liver looks like an abnormal shape. So the margins become undulating, the caudate lobe starts enlarging. This is an example. Another example, this is a normal liver and this is abnormal liver. But if you look at the axial images, I bet 9 out of all this is normal shape. But the moment you go into the coronal image, you see that the liver has this abnormal shape and the 3D is much more evident. It becomes a child's play to call this as abnormal liver. You see, none of these liver margins have any nodularity. Here it's little more advanced, the fissures are prominent and some degree of nodule is coming up, and this is how the liver looks. I also call it as the lumpy bumpy liver, and initially when it is swollen everywhere, I call it as a sumo liver. This is another example which is a fatty and abnormal liver, and there was a lesion. Well, this turned out to be adenoma. Any adenomas also need to be resected as they can develop HCC. This is what happens over time. So this is a patient from 2012. The liver attenuation index was -15. +5 is normal. In 2016, the liver index becomes +4, and this is a stage where LFTs also become normal. And then the liver is now heterogeneous, the spleen is enlarged, is almost into cirrhosis now. So see, this process is gradual. And this is like the honeymoon period where there is no liver fat, no abnormal LFT. Other causes like chemotherapy related, nutritional, especially in the post-Whipple's, and Colic, steatotic liver disease. Liver disease, the pattern is almost similar to that of liver non-alcoholic thing. So now we come to MR elastography. So we go into these stages. What is elastography? What is the pathophysiology of fibrosis? Type of elastography, and what is MR elastography? So the in the earlier days, palpation was an art. Was the major way to identify liver cirrhosis. You could palpate and find the stiff liver, but then that used to happen in a little bit advanced stage, so it may not be of any use in the early stages. So the elastography is new age palpation, and we hold that tool. I also say radiologists are the new internists now. So elastography is two types, strain elastography and shear wave elastography. In strain elastography, compressive force is applied and the stiffness is assessed, while in shear wave elastography, through ultrasound waves, shear waves are generated in the organ, and the velocity of these shear waves is measured. Let me explain this. So whenever you put pressure on an organ, the different layers in the organ are shifted, and a shape change happens. And when the shape change happens, it generates shear waves, and shear wave determines the based on stiffness of the organ. So stiffer the organ, the faster the speed. Like if the pitch is hard, it bounces where much more. So it's something like that. And this shear wave velocity is a surrogate marker of fibrosis. About resistance, so viscosity. So here we have two fluids. This one is water, and this is oil. When you drop a stone in the water, you have ripples which are of, these waves are of same wavelength and homogeneity is maintained. To drop a stone in the oil, which is very viscous, so the wavelength is larger, and it is not, everything is not homogeneous as in water. The second component is elasticity. So when you stretch this rubber, you release the pressure, it comes back to normal. So our liver is a viscoelastic structure. It has both viscosity, viscous as well as elastic. A good example is the shock absorbers in the car. How to generate shear waves? So there are two ways. One is external mechanical vibration on the surface of the organ. So that is done through the abdominal wall. So the two techniques are transient elastography, the fibroscan, and MR elastography. The second way is where you use focused beams of ultrasound which transmit the energy into the tissue of interest. This can also generate the shear waves. Liver elasticity depends on the parenchymal stiffness and the degree of fibrosis. So higher the fibrosis, higher are the shear waves. Stiffness also increases in following situation. So this can confound your results. So you should be aware of this. Inflammation, biliary obstruction, any congestion of the liver, like say this Budd-Chiari or cardiac cause, diffuse infiltrative disease like lymphoma, sarcoidosis, and metastasis. Blessing is that steatosis does not affect the stiffness. Stiffness decreases in regenerating nodules, the normal parenchyma between the abnormal and in necrotic tumors. So this is an example of showing you the fibroscan, which is used by gastroenterologists. They have this probe, and through this probe, they send mechanical sound waves, and they make results out of it. And this is elastography. And this is an example of ultrasound. So in ultrasound, you identify the area of interest. The ultrasound beams will generate those shear waves only in this area. So you get more segmental information here. This is a comparison. So as of now, the most accurate way is MR elastography, because it is highly accurate, and one of the important thing is those external the beam, which is those sound waves which are sent to liver, are at same frequency, 60 hertz. It is monochromatic. It is standard across all vendors. So like if you do elastography on a Siemens CT, next time you can do on a GE or a Philips scanner. Scan is very good to identify a grade 4 fibrosis, but it is not good at identifying those stage 2 or stage 3. Now stage 2 or stage 3 is the critical phase where you can intervene and cause some reversal of fibrosis. But ultrasound is very widely available. It is cheap, and so there is at least you don't have to do MR elastography in all cases. So that is the mission IRA is running right now, and promoting ultrasound elastography. So again, those benefits of MR elastography, it is independent of strength, 1.5 T or 3 Tesla. And there are no bias, standard across vendors. Repeatability and reproducibility is there. And it is closest to biopsy. So the accuracy is quite high. This is tell you how the thing is done. There is an active driver which sends those sound waves, and it is kept outside the gantry area in the non-magnetic area. Then through a plastic tube, these sound waves go into a passive driver, and this passive driver is kept on the liver. So continuous vibrations are coming at 60 hertz, which are monochromatic, and reaching up to the liver. So what happens? The shear waves are generated, and those shear waves are identified by a gradient sequence, and which is then the information is transmitted in the form of a map, which is visible to us, and it has a color coding. So like blue and purple is like normal, and red is like a grade 4 fibrosis. So one, you have a quantitative, just by visible looking at, you can make out there is fibrosis. And secondly, you can create ROIs and give actual value, which is called as KPA value. The core components of MR elastography is optimization of the technique, maintaining the quality and appropriate interpretation. We'll go to cases. Actually, it's a long talk. I want to show cases rather. So in MR elastography, you get 6 set of images, but the main what we should know is one is the magnitude image, which tells you which part of the liver was studied. This is a elastogram with a confidence map. So wherever there is a checker is not a good area to measure. So anything without checker is the right thing. And this is the wave map, which tells you that the waves are traveling. So in a normal liver, as the waves move to the center of the organ, they are dampened and they have more darker areas. So if you see a central image a bit darker on the wave thing, then you know we are looking at a normal liver. So what you do is you create ROI in the entire image of that elastogram at 4 different places, and then you create a mean value, and that is called as the mean KPA. So there are different cutoffs in the KPA. Anything 2.5 or below is normal. Normal meaning there is no fibrosis. And as I told you that inflammation increases the stiffness. So on MR elastography, you are able to tell if this patient is simple fatty liver or steatohepatitis, which is inflammation. So the cutoff for that, there are various cutoffs. 2.7 is a good cutoff for inflammation. And anything above 4 goes into advanced fibrosis. So let's jump to the cases. This is a fatty liver, around 17%, MR elastography, normal waves, normal blue and purple color, and the values were less than 2.5. So this is a simple steatosis. Another patient, diabetic, you can see there is some morphological change. There is like a significant fat. There is normal elastogram. Again, that's a good news for the patient. Patient where there is a lot of fat in the liver. This is actually a fat image, not the outface. The fat percentage is high, and the liver was slightly on the stiffer side, and this was F1, F2 fibrosis. So we are at the inflammatory stage. Here again, you don't see any nodularity on the surface. Some enlarged caudate lobe, you have a lot of fat there, but there is a higher grade of fibrosis. So here is the scale. We are going orange, and then you create the ROI values, and this was grade 4 fibrosis. Now, even for liver biopsy, for histopathological evaluation of liver fibrosis, you don't need to do a biopsy. Do it with MR elastography. And why it is good? As I told you that fibrosis never starts everywhere at the same time in the liver. So if you say biopsy the liver from this area, it may come like normal. But if you biopsy from this area, it may come as F1 or F2 fibrosis. So before considering invasive biopsy, always do elastography. So instead of making these small measurements, the standard practice is to take 4 elastograms, create a ROI for the entire liver, and create a mean. Now, this is a patient, you see here is there is significant fat, liver has little altered morphology. In 2017, the KPA was 3.1. Follow-up in 2 years, the inflammation has reduced at cases, and the KPA is coming to normal 2.4. But say if I had to biopsy this area or just create a ROI on this side, then I might say that there is more fibrosis. But here we are looking at the overall burden to the entire liver. So this means the patient is responding to the treatment and to continue with whatever measures being taken. Here, quite a abnormal looking liver, severe fat, almost 30%. Elastography shows grade 4 fibrosis. So this is a MET ALD patient where patient is also having diabetes as well as he's taking alcohol. Liver is severely fatty. What I see like this was my one of the initial cases. I was so excited. I said the entire liver is cirrhotic, but the GGT was like 1600. So mind it, the liver is quite inflamed. And as I told you, the fibrosis doesn't happen at the same place everywhere at the same degree. So this was nothing but acute alcoholic hepatitis. So you have to keep in mind and not call it as grade 4 fibrosis. Now, sometimes the MR elastography is not very good. The confidence map is very small, but don't get disheartened because this is still better than doing a liver biopsy. This is a unfortunate patient who had live liver donor transplantation in 2016. I don't remember how, this may be like 5 or 6 years later. The cause which was initially present, maybe it was diabetic fat or hepatitis, whatever. This patient developed cirrhosis in the donated liver also. The case of liver transplantation, here the liver is increased stiffness, but then there is biliary obstruction also. So biliary obstruction gives false findings. This is just wrong positioning. Important thing which is now called as lean NASH. So people may look, this patient, people will say you are quite fit because you don't have fat, you are not obese, but then this patient internally is not fit. It has fatty liver, and then there is almost grade 2, grade 3 fibrosis. So your looks can be perspective. There is iron overload, and MR elastography doesn't perform well with iron overload, so you have to reject the study. This is a patient who had a MR elastography in February 18. There was some inflammation. Patient was on treatment, but then the weight was increasing. And when we did the MR, the inflammation is also increasing. So either the patient is not taking appropriate treatment or you need extra interventions. This is a case of autoimmune hepatitis. This is just an advanced cirrhosis. There is hardly any fat in the liver. This is a case of congestive cardiac failure, but this patient has now developed cirrhosis. But remember, congestion can confound your values. So in the patients who had Fontaine surgery, they are at risk of developing liver fibrosis. So MR elastography is used for the follow-up of these patients. This is a case of non-cirrhotic portal fibrosis. So NCPF, there is fibrosis, but it is along the portal vein branches, and the liver is not cirrhotic. So liver may look abnormal, but then on MR elastography, there is no fibrosis. This is hepatitis C plus patient had fat. So double whammy fibrosis. You must have noticed that oncology patients, cancer patients get chemotherapy, and those chemotherapy can be hepatotoxic, and they are prone to develop liver fibrosis. This is a patient who's on tamoxifen, and there is inflammation in the liver, early fibrosis. So I'll end here. The take-home message is not Brexit, but the fat exit is what we focus on. Multi-MRI, multi-echo Dixon-based fat quantification and MR elastography are the two accurate one can rely on. So you can quantify fat, quantify fibrosis, and add appropriate intervention in the patient's treatment. So thank you, REF, Akshay, and everyone else who is attending this talk. I'm active on social media. I'm on Twitter as abdo_imaging. That is IRA preventive imaging. That's my own site, abdominal imaging on Blogspot. Akshay?
Thank you so much, sir.
My pleasure.
And very exhaustive talk covering, I think, a lot of important, both practical and basic fundas about how all of this happens. And even in Tata, we are seeing more and more HCC patients who are non-cirrhotic, non-hepatitis B, non-hepatitis C, all because of MASH LD. So this is only going to rise substantially in the future.